Placebo is usually treated like the least interesting part of medicine, the fake pill, the control group, the thing that is not supposed to do anything. But that is exactly what makes it interesting because sometimes something does happen. Pain changes, symptoms shift, the body responds in ways we cannot explain. The real question today is not whether placebo is real. The question is, what kind of real is it? Before we go any further, a placebo does not contain an active drug. It might be a sugar pill, a saline injection, a fake capsule, or a simulated procedure. But that does not mean the body does not respond, as we will see. One of the clearest examples comes from Parkinson's disease. Here, the disease and the dopamine system are tightly linked. Dopamine is not just a pleasure chemical the way it is often described. It is also deeply involved in movement, motivation, reward prediction, and anticipation. In a 2001 study, scientists used PET imaging to look at dopamine activity in patients with Parkinson's disease. The scan used a tracer called raclopride, which binds to dopamine receptors. When the brain releases more of its own dopamine, less of that tracer can bind. So, this gave researchers a way to watch for dopamine release indirectly. The patients received a placebo under blinded conditions. In other words, they did not know whether they were receiving the active drug or not. And after the placebo, the researchers found changes consistent with dopamine release in the striatum, a region involved in movement and one of the systems affected in Parkinson's. The numbers were striking. After placebo, raclopride binding dropped by about 17% in the caudate nucleus and 19% in the putamen compared with open baseline observations. That pattern suggested the brain had released more dopamine on its own for these patients. And that does not mean a placebo can cure Parkinson's disease, but it does mean the expectation of treatment can reach into real disease-relevant circuitry. And later work made the story even more interesting. In a 2010 study, researchers tested whether the strength of expectation could change dopamine release. Patients were divided into 4 groups and told their chance of receiving active levodopa was either 25, 50, 75, or 100%, but everyone received a placebo. The significant dopamine release happened in the group told they had a 75% chance of receiving the real medication, but not the other probabilities. The authors concluded that belief in improvement can directly modulate dopamine release. This is interesting because the body was not responding to a medication. It was responding to probability, expectation, prior experience with the medication, essentially the meaning of what was about to happen. So placebo can be real, but that does not mean it changes every part of the body in the same way. And one of the best examples of that comes from asthma. Asthma gives us 2 different things to measure. One is how a person feels. Do they feel like they can breathe better? Do their symptoms seem improved? And the other is what the lungs are objectively doing. Are the airways actually opening? Is more air moving out of the lungs? In a 2011 study, researchers compared 4 different interventions in people with asthma. The study was designed to separate the effect of the actual drug from the effect of receiving treatment. Patients had multiple visits and received 1 of 4 interventions: an active albuterol inhaler, a placebo inhaler, sham acupuncture, and no intervention, meaning no treatment or placebo. Albuterol is a common medication given for this condition because it can open airways, making it easier to breathe. And in asthma, researchers can measure that directly with a lung function test called FEV1. Basically, it measures how much air a person can forcefully breathe out. And on that objective measure, the active medication won. Albuterol improved FEV1 by about 20%. The placebo inhaler, sham acupuncture, and no intervention groups were all around 7%. So when the researchers measured what the lungs were actually doing, placebo did not perform like a real medication. But then the study got stranger. When patients were asked how much better they felt, the differences almost disappeared. Patients reported about 50% improvement with albuterol, but they also reported about 45% improvement with the placebo inhaler and about 46% improvement with the sham acupuncture. The no intervention group was much lower at around 21%. So this study gives us an important data point. Placebo can change how symptoms feel from the inside, but that does not always mean it changes the disease in the same way as an active treatment does. But what would a placebo do in a situation that involves physiology where the person is not consciously sensing it at all? One of the most interesting examples comes from kidney transplantation. In the United States, this procedure is not rare. In 2025, there were over 27,000 kidney transplants and more than 90,000 Americans still waiting. But getting the new organ is not the end of the story. After a kidney transplant, the immune system can recognize the new organ as foreign. So patients have to take immunosuppressive drugs to reduce the risk of rejection. And those drugs help with this enormously, but they also come with difficult trade offs. Some of the major immunosuppressive drugs used after kidney transplantation can have serious adverse effects. The kidney transplant study we are looking at lists problems such as cardiovascular morbidity, nephrotoxicity, neurotoxicity, and hypertension. Nephrotoxicity means toxicity to the kidney. So the cruel part is obvious. Some of the medication used to protect the transplant can also be hard on the kidneys, and over time, that kidney toxicity can contribute to kidney dysfunction or even failure. And that is why researchers have been interested in a very specific question. Can the body learn part of the treatment environment so that someday, maybe, the same immune control could be achieved with a lower drug dose? In a fascinating 2018 study published in PNAS, they tested this idea in 30 renal transplant patients who were already receiving immunosuppressive therapy. The researchers used what they called a taste immune conditioning paradigm. The hope was to pair the medication with a sensory signal the body could recognize. Patients took their real immunosuppressive medication together with a distinctive taste cue. Later, the patients stayed on their normal medication schedule, but at additional points during the day, they were given placebo pills with that distinctive drink. And then researchers looked at immune activity in the blood, and their experiment worked. After the learned taste placebo was introduced, the patient showed a significantly stronger immunosuppressive response, more so than they did under the usual medication routine alone. And because the medication dose stayed the same, the result was not due to an increased amount of the drug. Here, the immune system and the body had learned an association. A taste plus a medication equals an immune shift. The authors describe this as proof of concept. Learned immunosuppressive placebo responses could potentially be used as a supportive placebo-based dose reduction strategy. Again, this is early, it was a small study, but as a biological clue, it is remarkable. And this idea does not only appear in transplant medicine. A similar logic has been tested in ADHD. In a 2010 study, researchers asked whether children with ADHD could maintain symptom control on a lower dose, a stimulant, when being paired with a placebo. The study included 99 children ages 6 to 12. First, the researchers identified each child's best effective dose. Then the children were assigned to one of three groups. One group stayed on their full dose, one group had the dose reduced by 50%, and one group had the dose reduced by 50%, but also received a visually distinctive placebo capsule that had been previously paired with the medication. Here, the placebo was not hidden. There was no deception. Parents and children knew that they were participating in a conditioned placebo dose reduction strategy. And the results were interesting. Most children in the reduced dose only group, meaning no intervention, they got worse. But most children in the reduced dose plus placebo group stayed stable. In this study, a learned treatment cue seemed to help some children maintain the same benefit on a lower dose. So now we have seen the same pattern in two very different places. A kidney transplant study where a taste cue was linked to an immunosuppressive response, and an ADHD study where a distinctive placebo capsule was used alongside medication reduction. In both cases, the participants knew what was happening, and the placebo was not pretending to be medicine. It was being used as a learned signal, a cue that the body had come to associate with treatment. Next, placebo becomes less about the inactive pill and more about the treatment encounter. In a 2008 BMJ study, researchers looked at patients with irritable bowel syndrome, or IBS. IBS is a condition where people experience symptoms like abdominal pain, discomfort, bloating, diarrhea, constipation, or changing bowel habits. The researchers wanted to know whether different parts of the medical encounter could be tested. So they divided patients into three groups. One group was put on a waiting list, one group received placebo acupuncture with very limited interaction, and one group received the same placebo acupuncture but with an enhanced patient practitioner relationship. In this group, they received warmth, attention, empathy, time, and confidence that the treatment could help. The results followed a clear pattern. After 3 weeks, 28% of the waiting list group reported adequate relief. That number rose to 44% in the group that received fake acupuncture with very limited interaction. And then it rose even higher to 62% in the group that had received the same fake acupuncture, but with patient centered care. The researchers concluded that placebo effects can build in layers and that the patient practitioner relationship was the strongest part of the response. Now let's look at the most dramatic version of the placebo effect: surgery. In 2002, a study in the New England Journal of Medicine looked at patients with osteoarthritis of the knee. These were patients with knee pain who were randomly assigned to one of three groups. One group received arthroscopic lavage, where the joint is washed out with fluid. One group received arthroscopic debridement, where the joint is washed out and damaged tissue or loose debris may be removed or trimmed. And one group received a placebo surgery. In the placebo surgery group, patients still went through the usual surgical setting. They were brought into an operating room, they received sedation, they even had small incisions made in their skin. The surgeon went so far as to act out the procedure, but at no point was an arthroscope inserted. No surgery was done. Now, that is an intense placebo, not a sugar pill, not a fake capsule, a full medical ritual. At 1 year, knee specific pain scores were similar across the placebo, lavage, and debridement groups. At 2 years, they were still similar. So at no point during the 24-month follow up did either group that received the actual procedure report less pain or better function than the placebo group. In this study, the actual arthroscopic procedures were no better than the simulated surgery for osteoarthritis of the knee. Perhaps because surgery carries such enormous meaning: the hospital, the anesthesia, the recovery, the belief that something physical was repaired. Here, a placebo does not have to be a pill. Sometimes it can be an entire surgical performance. So by this point, placebo is no longer looking like one thing. In Parkinson's disease, expectation was linked to dopamine release. Asthma symptoms shifted even when lung function did not change in the same way. In kidney transplant patients, the body learned a medication cue. In ADHD, placebo was used as a learned signal alongside a reduced medication dose. In IBS, the relationship changed the strength of relief. And in knee osteoarthritis, even a simulated surgery produced outcomes similar to the real procedure itself. So maybe placebo is not one mechanism. Maybe it is a category of responses. A 2010 review in The Lancet described placebo effects as a genuine psychobiological phenomenon connected to the overall therapeutic context, not simply the inert content of a pill. It also emphasized that there is not one placebo effect, but many, involving conditioning, learning, memory, motivation, anxiety reduction, reward, and meaning. And meaning can be surprisingly important. Even before a medication does anything chemically, its appearance can already shape expectation. In a 1996 BMJ review, researchers looked at studies on drug color and found a general pattern. Red, yellow, and orange were more associated with stimulant effects, while blue and green were more often associated with a more calm or tranquil state. The review itself was cautious, but the point is fascinating. Before a pill dissolves, it already has meaning attached. Its color can mean something, its size may mean something else. A capsule may feel different from a tablet. An injection may have a larger effect than a pill, and a procedure may carry an even stronger signal. Another important point is that treatment is never received in isolation. The body encounters it inside a story. What has helped before, what the doctor says, what the room feels like, what the treatment seems to promise. The placebo shows that meaning can become part of the body's response to treatment. But there is a shadow side to this. If meaning can help the body feel safer, meaning can also make the body feel threatened. This is called the nocebo effect. Negative expectations, fear, warnings, prior bad experiences, and anxiety can shape symptoms too. The body can respond not only to the promise of relief, but to the anticipation of harm. So, meaning is not automatically healing. Meaning is powerful because the body takes it seriously. In closing, the placebo is real. It does not mean that illness is imaginary. It does not mean belief cures everything, but it does reveal that the body is not only a chemical machine waiting for active ingredients, it is an interpretive system. It responds to molecules, but it also responds to expectation, memory, relationship, and the meaning of what it thinks is happening. I cannot wait to hear your thoughts on this topic. And until next time, stay curious and take care.